Welcome, everyone. Thank you so much for joining us today. My name is Tram Lam. I am the Program Director in the Epidemiology and Genomics Research Program at the National Cancer Institute. On behalf of NCI and Dr. Lisa Galicchio, the co-chair of the Research in Understudy Population and Cancer Disparities webinar series, I would like to welcome you to our June 2021 webinar with Ms. Mira Serrano. This quarterly webinar series is designed to highlight research on both understudied populations and disparities associated with outcomes across the cancer control spectrum. Today's webinar's host is Dr. Janet Sanchez, who is the Program Director in the Healthcare Delivery Research Program. Before Dr. Sanchez introduces our speaker, I want to provide some quick information on the webinar platform. All lines have been muted on entry and remain muted for the duration of the webinar. Please submit your questions throughout the presentation using the chat and select all panelists. A moderator will ask the comments or questions on your behalf at the end of the presentation. If you require technical assistance, please feel free to email the host via the chat panel, and they will be happy to assist you. If you need closed captioning, please refer to the link in the media viewer and chat panels. I also want to make you aware that today's webinar will be recorded. And now I'd like to turn it over to Dr. Sanchez to introduce today's webinar and our speaker.
I want to thank everybody for joining us today, and I'd like to introduce Mira Serrano, who has been Senior Manager at the Center of Community Alliance of Research and Education, which is also called CCARE, which is part of City of Hope's Community Outreach and Engagement Center. As a Senior Manager for CCARE for 14 years, she has built partnerships with community advocates and other multi-sectoral stakeholders to develop and implement community participatory programs and interventions to reduce the risk and burden of chronic illnesses, including cancer, obesity, and diabetes. She is currently pursuing her Doctor of Public Health degree at the University of North Carolina at Chapel Hill, and I would like to also state that she recently passed her dissertation proposal defense, so congratulations to Mira. And today's webinar will highlight findings from 2 research studies focused on reducing the risk of developing recurrence among Latina breast cancer survivors through multi-level nutrition and physical activity interventions, as well as how community engagement strategies could be leveraged to build community capacity in the Latinx community. With that, I'd like to welcome Mira.
Thank you, Janet. And thank you, everybody, for joining us today. And I want to say good afternoon to those in the East Coast and good morning to everybody else. So thank you for joining us. And so today we're going to discuss a few studies that we've done at City of Hope on the Latino community. So here, as I mentioned, we have, I'm going to discuss 2 studies and what we've done with that, and 2 studies that specifically talk about community engagement. So the title of today's talk is Para Nuestra Comunidad, which translates to For Our Community, talking about the collective culture of Latinos. And we're going to discuss how to address the needs of the Latino community, the Latinx community. So first, we're going to talk about a study called Eat, Move, Live. And Eat, Move, Live started as a community program, and it's a program that I started back in 2008. And it was just a community program that would take place at the local elementary schools. It was a 5-week program. And then from there, the program was really successful. We weren't measuring weight change. We weren't really measuring anything different besides knowledge, because in 5 weeks, it's hard to capture that kind of information. But from there, it grew. It really grew from a community program, community health education program, to a research study. So it's really a great example of how you can move research from community to bench. So we started with a pilot study, and it's really a community-based nutrition and physical activity intervention with the aim of reducing the risk of type 2 diabetes in Latinas. That's how it started. And the pilot study was really a feasibility trial, and we had a pre and post test. We had a waitlisted control group to assess, the possible positive effects of the nutrition and exercise intervention. And it was really targeting underserved Latina women that were at high risk of developing diabetes. Now, the intervention that we used, we were testing the effectiveness. So we did a randomized delayed control design. And so Eat Move Live is really, like I mentioned, community-based, and it's this participatory multi-level intervention. And it's a free program that we were offering. It's culturally and linguistically appropriate nutrition and physical activity sessions. And what does that mean? That means we're using recipes that are relevant to the Latino community. It's hard to introduce sometimes new foods that people aren't used to, don't know how to cook, don't know what to work with. But if you introduce recipes that are already part of the culture, with just some swaps that make them healthier, people were more likely to be receptive and more likely to actually integrate those into their daily lives. Now, Eat Move Live was one of the most important factors of Eat Move Lived was that it was community-based. And so we had partnered with a lot of different community agencies to actually implement the program. So it's really implemented in collaboration with these organizations. And it really is a way to establish innovative partnerships, right? And it allows us to create an open, two-way conversation. It's really built on engagement and trust. And it's also building and enhancing community collaboration and capacity as well. The program, outside of the program, sometimes we just provide physical activity classes, food demonstrations. Once the program ended, people don't want us to go and they invite us to come back, and we come back and do monthly or quarterly classes. So it's a really community-based engagement effort. Now, for this pilot study, again, the aim was to look at insulin resistance. So we really wanted to improve healthy eating and physical activity, including BMI and other metabolic markers like hemoglobin A1C, fasting plasma glucose, among these high-risk Latina mothers. So these were women who weren't eating the recommended amount of fruits and vegetables a day. They weren't exercising the recommended 150 minutes a week of physical activity. We had specific eligibility requirements to qualify as high risk. And they were either overweight or diabetes ran in their family. And actually, it took place at the schools. It was at the local school district. And the schools were randomly assigned to a condition. So 2 schools were randomly assigned to intervention, 2 schools were randomly assigned to control, to the waitlisted control. Now, the class was 12 weekly classes, and the reason it went from 5 to 12 weeks was that we were measuring A1C, and A1C is the average blood glucose over 3 months. So we needed to see where that change was happening. So the class became 12 weekly 2-hour sessions that really, provided education, coaching, and skill building, covering nutrition, cooking, physical activity, provided social support, and also taught community advocacy. So it consisted of 1 hour healthy lifestyle education and discussion was led by a health educator, 30 minutes of physical activity led by a certified fitness instructor, and a 30-minute healthy cooking demonstration with a taste test. Now, the topics included things like My Plate, how to read nutrition food labels, covered portion sizes. As I mentioned before, we included recipes that were healthy but culturally relevant. We actually would bring our registered dietitian that you can see here in our picture, and we took our members grocery shopping to show them how to grocery shop. So we did a tour of the local grocery stores. We also covered how to eat healthy on a budget to bust the myth that healthy eating is expensive. And then with the issues of food security, we also covered how to reduce food waste. So how to store your food, where to store it, and how to make food last longer and how to use that food that's about to go bad. And then we also covered diseases and how to reduce your risk in terms of cancer, early detection and screening, diabetes and heart disease, and even covered issues of mental health and body image. And those issues were covered because it was requested from our participants and from our community partners. Now, the participants, as I mentioned, engaged in moderate activities. So we did things like dancing, yoga, Zumba, resistance training. And we had them set goals that were, of course, SMART goals For the participants, they were set 3 goals at the beginning of the program, and then at the end of the program, see if they met those SMART goals. And then we tried to have them incorporate these new behavior patterns as part of their daily lives, whether it was 10 minutes at a time, whether it was walking around the neighborhood, whether it was watching free YouTube videos. You know, we wanted them to know that physical activity didn't have to mean going to the gym and getting a membership. And then we offered them the tools necessary to complete these activities. So when we did yoga, we gave them yoga mats. So those blue mats that you see there are actually the ones that we gave them. And then we also, for the resistance bands, we gave them resistance bands as well. And then for the pilot program, we actually paid for them to have a free family pass to the city's fitness center for them to take advantage of those classes. And then we provided free information about the recreation centers and local fitness classes. So because this program was targeting Latinas, 100% of the participants self-identified as Latina or Hispanic. We see here that the majority were low income, made less than $25,000 a year, and that was their household income. The majority of them had less than a high school education, and the average age was about 41 years old. Now, the participants were recruited via the schools. So we started off with flyers distributed through the school system, through the students, but for many of you parents, I'm sure you know that sometimes those flyers do not get to you. So then our staff actually did in-person recruitment at pickup and drop off, and that actually was more successful for us and worked much better. We ended up with a total of 38 participants that enrolled out of the 50 that were screened and recruited. So 38 actually completed the baseline survey. And as I mentioned, the mean age was 41. And then most of them didn't have a high school education. And our mean weight was about 173 pounds. The average A1C was 5.9, and that is in the pre-diabetic range. But we did have the range from 5.0 to 7.5. The most interesting part of that is that 2/3 of the women who were diagnosed with prediabetes or diabetes as a result of participating in this program didn't know they have it. So 2/3 had undiagnosed prediabetes and diabetes. And we actually had an endocrinologist with us to counsel the patients when they received their results. And then the average BMI was about 31, which is considered obese. But there was no significant differences in terms of the control group and the intervention group. Now, these are the results from our intervention group. So you can see here at 3 months, we took their A1Cs at baseline, at 3 months at the end of the program, and then at 3 months post the end of the program, because we wanted to see if the intervention was sustainable. Did these women sustain their behavior changes 3 months after the program ended? So you can see here that in the intervention group, most of them actually had their A1C lowered. Now, compared to the control group, you can see that while the control group was waitlisted, while they had no intervention, there was really not much change in their A1C, but you can really see that they started the classes at the 3-month point. So control group actually had 4 time points: at baseline, at initiation of the program, which was at 3 months, at completion of the program, which was at 6 months, and then 3 months post end of the program at 9 months. But we didn't see too much change in BMI. We saw the change in A1C, which was really interesting, that we saw a change in insulin resistance and in their blood sugar, but there wasn't too much weight gain. Now, lesson learned here, for any of you who are trying to do a nutrition intervention, do not do the endpoint near a holiday. We ended our program around Christmas time, and we were measuring these women about January. And one of the things that the ladies were saying, they're like, well, I gained weight during Christmas. You know, I had a lot of tamales. So maybe do not do it around that time. We learned our lesson that it actually, you know, weight fluctuated more. And so we've tried to stay away from that date since then. But we haven't seen a change in BMI. So, you know, what we're theorizing is that the women made enough changes in their lifestyle in terms of healthy eating and physical activity to change their blood sugar, to change that metabolic marker, but maybe not enough to be in a calorie deficit to lose weight. And so, but then we did see them losing inches. So perhaps, you know, what they were gaining in muscle mass, they were losing in fat as well. So we actually think maybe we need to explore this further to see what it is that's improving that A1C. And here's the BMI, again, for the control group so that you can see that. So we really showed that this multi-level approach of cultural exercises, decreased sedentary lifestyle, nutrition, you know, all this food preparation knowledge and skills really enhances the acceptability and effectiveness of the program. 83% of our ladies completed 75% or more of the classes. 12 weekly classes is a lot for parents. We didn't have daycare, but they were more than welcome to bring their children with them. So it was really active classroom that you'll see in some of the pictures, you know, babies are in there, you know, strollers or moms working out with their children. But we really see that it was really acceptable. They were wanted to come back week after week. And our hypothesis was that increasing the levels of exercise to the CDC recommendation and providing these classes really improved A1C among these Latina women. Now, after that pilot study, we thought, okay, wonderful, this program is improving blood sugar, let's expand it. And now the current program has been implemented 19 times with 19 community partners, 15 of those in person and 4 of them virtual, because one of our programs was interrupted by COVID. So we actually had to create our program and transition to a virtual version of this program. Now, for these participants, they were recruited by our community partner via flyer or word of mouth. We've reached 488 participants. 44% of those, which was a majority of them, self-identified as Latino or Hispanic. Most of them were female. Again, most of them are low income. Most of them have a less than high school education, and most of them are Spanish speakers. And then we also have a large percentage receiving CalFresh, which is California's version of the SNAP program. Now, the demographic data focuses just on the Latino participants. Our second largest group in this extended program was Black and African American, made up about 35%, and then Asian made up about 16%. Now here's a little bit of the gender and age in terms of our Latino participants. As you can see, the majority were women. The majority were middle-aged, 45 to 64 years old. And then most of them spoke Spanish. Most of them, if you can see here, most of them made less than 25,000, but almost a little over a third made less than 15,000 for their household income. Now, again, here, this is the insurance breakdown in terms of private and the state agency. Medi-Cal insurance was the largest, and that's California's version of the Medicaid. And most of them rated their health as fair in about 60% of them at baseline. And then these are the changes we saw from pre to post. So in terms of those who said they had difficulty eating healthy for different reasons, we saw a 36% increase in the number of participants who said it's not difficult for them to eat healthy anymore after the program. Some of those barriers were not having time to prepare healthy meals. So we saw a 53% decrease in the number of people who said they had no time. Another barrier was not knowing how to prepare those healthy meals, and we saw a 68% decrease in that, people saying they didn't know how to prepare healthy meals. We also thought, some people thought, you know, eating healthy was expensive, so that was a barrier to eating healthy. So we saw a 70% decrease in those saying it was too expensive to eat healthy. Some people said they didn't know what food to buy, and we saw a 56% decrease in the number of people who said they didn't know what to buy. And another barrier was not knowing how much to feed their family, and we saw a 75% decrease in that. And then for physical activity, at the onset of the program, we saw a lot of people saying that they had difficulty staying healthy, and at the end of the program, that reduced by 35%. And then 42%, there was a decrease in those who said they were too tired or lacked the energy to be physically active. And then we see here the largest decrease here is in the statement, I don't know how to become physically active. And so we saw an 87% decrease from baseline of those who said they didn't know how to become physically active. And then here we have A1C for our larger program. 53% of the participants lowered their A1C. And in this program, we saw 58 participants lose weight, and maybe because we had a larger sample size here. The average weight loss, of course, was 2.25 pounds for those who lost weight. But we also saw changes, as I mentioned, in body measurements. But here, the most important part is actually sometimes the testimonials, right? The qualitative results that we see. And in one, we had a woman who didn't know she was diabetic, and she said, I found out I was diabetic when I registered for the program. I was able to find a clinic that can help me manage my diabetes. So we were able to connect her, because she was uninsured, to a local FQHC, and her A1C dropped 3.4 points during the program. So, we were able to get that under control for her. And then we see other things like confidence, changing confidence that we weren't measuring. And one gentleman said that he really enjoyed working out, and it helped him build his confidence to continue exercise outside the program. Oftentimes people don't exercise because they're not confident, or they're self-conscious about their weight or their size, and they don't feel comfortable going to a gym. And so after working out in the program, they built a lot of that confidence and were able to go out and exercise. So again, this really showed that, the program is effective, and that we were able to lower A1C, we were able to improve it and improve the BMI status with these Latino families. Now, our next steps is we're implementing this for an R01 in looking at far zip codes and food deserts. So implemented in those areas. We're also starting a study with breast cancer survivors who have insulin resistance post-treatment. And we're currently recruiting patients, and it's patients in those far zip codes and in those food deserts at our local community practice site. And a lot of times breast cancer survivors are concerned about their weight because of the risk of recurrence, but they struggle with weight loss. And this program fits perfectly with working with those patients so that we can help reduce their insulin resistance, to help with their weight loss, to help reduce the risk of recurrence. And then, as I mentioned, because this is a community-based program, it's really important that as part of the work that we do, we're also building community capacity. So a lot of the program managers from our community partners are going to be part of our Train the Trainer program. We have developed a trainer manual for our program so it can be implemented at these community sites, so it can lead to sustainability. We don't want us to leave and then they have no more nutrition and physical activity program. So these community partners are going to be trained on how to implement the program. But most importantly, we are also wanting to include a funding mechanism, because we can't just give them the tools and then say, good luck, find your own way. We want to have this pilot program funding, so those that actually participate in the Train the Trainer program can actually have some funds to actually implement the program. The program can be inexpensive, or it can be expensive. For us, we give Fitbits, which are the most expensive part, as an incentive to complete the program. So those that finish 75% of the classes receive a Fitbit at the end of the program. In our pilot study, we gave it at the beginning of the program and learned our lesson that maybe we should do it at the end, because a lot of people came at the beginning and just took the Fitbit and never came back. Or people lost the Fitbit or didn't know how to use it. And that was another interesting finding, and we have a paper under review on that, on knowing on the digital divide. A lot of our older monolingual Spanish-speaking participants didn't know how to download an app or do an email or complete a survey on RedCap or on a tablet. And so we're discussing, those needs of that community and how digital sources and tools might not be the most optimal for this population for that reason. Really, it's really come to light during the pandemic, this digital divide. But I just wanted to mention, the importance of providing this funding for the community capacity building for our community partners. Now, next, I'm going to talk a little bit about another project that we did with our Latinx LGBTQI community. Again, a very community-based project that was done through the Latinx Task Force, made up of a lot of different agencies throughout Los Angeles County. And so this really started from us witnessing a speaker make some very not nice remarks about the LGBTQ community, and we realized we need to vet our speakers better. And then we decided we need to address the needs of our LGBTQ community. They're underserved, and we really don't. We know there's a dearth of information when it comes to the data because we're not collecting it. And then for cancer needs, it's even worse. So there's over 1.6 million individuals that identify as LGBTQI+ in California, and the majority of them live in Southern California. We know that these individuals have unique healthcare needs, but studies show that over half of them have reported experiencing discrimination in care, and as a result, 1/3 have not shared their identity with their healthcare providers. We know there's a lack of culturally competent providers and staff, and this becomes a structural barrier for accessing care and receiving quality care for many LGBTQI+ individuals. So as a result, we developed, the Latinx Task Force developed a survey in 2017, and we discovered that there's a growing need for Latinx LGBTQI culturally competent trainings because we need to create welcoming and respectful healthcare environments for our Latinx LGBTQI individuals. So we had 193 respondents, and the majority of our respondents, 78% were Latinx. And the survey was promoted through community partner networks, social media, our Latinx Task Force website, flyers at community events like at Pride events. And here's the breakdown in terms of the age of the participants. So most of them were young adults, as you can see from here. And then here's the gender identity. We included cisgenders, trans, and then non-binary. And you can see the breakdown here. The majority of them identified as cis females. And here's our breakdown for sexual orientation. And the percentages here don't add up because we allowed select all that apply. But our most common response here was gay and queer. And here's how they rated their health. So most of them chose either very good or good in terms of rating their health. And then here's the data on whether they had shared their gender identity or sexual orientation with their doctors and healthcare providers. So we see that the majority had shared it with all of their providers or at least some of their providers. Now, the respondents who were less likely to share their gender identity or sexual orientation identified as bisexual or pansexual. And those who were more likely to share their gender identity were identified as gay. Now, when asked if they thought their providers were knowledgeable in terms of LGBTQI+ health, you can see here that most of them thought, well, somewhat knowledgeable, but we also had a large percentage who said they were not too knowledgeable. And then for this one, those who were more likely to state that their healthcare providers were knowledgeable about LGBTQI health were those who identified as gay. And those who were less likely to state that their providers were knowledgeable identified as pansexual, and that those were all statistically significant. Now, in terms of the question, this is the one that's driving a lot of our work. The question was, have you ever been afraid to share your gender identity and or sexual orientation with your healthcare provider? And as you can see here, 71% of the respondents have been afraid to share their gender identity or sexual orientation with their healthcare provider at one point or another, right? So this includes those who said always, often, sometimes, or rarely. But the majority, 57%, said they were afraid sometimes, often, or always. And so this is completely unacceptable. We obviously need to create more welcoming and inclusive environments for people to not be afraid to share this information. So the respondents who were more likely to state that they've ever been afraid identified as queer, and that was also statistically significant. Now, here is, we asked if when they receive healthcare, would they prefer to go to somebody who was LGBTQI trained? And here you can see, of course, that the most common response was yes at 69%. Those who responded that they would prefer were more likely to identify as queer. And then we started asking questions about health behaviors, things that might affect their cancer risk. So here we asked if they've had a pap test, and we split it up in terms of the eligibility requirements. So for those that were between the ages of 21 to 29, we asked, have you had a pap test in the last 3 years? Now we didn't the only thing we selected for was age. In terms of gender identity, we didn't. We left it open. So the options were yes, no, I don't have a cervix. So as you can see here, we had 56% that had not had a pap test. So the majority had not had a pap test in the last 3 years. So we see here the majority of the group is not within the guidelines for pap testing. And then for those who were over 30, from 30 to 64, we asked if they had a pap and HPV test in the last 5 years. Here, the majority said yes, so we had 74%, but that number still falls below those healthy 2030 goals. And then for here, the respondents who were more likely to have a pap test in the last 3 years between the ages of 21 and 29 identified as cisgender females or bisexual. For those who were 30 to 64, those who were more likely to have a pap test and HPV test also identified as cisgender females. Now, we also asked if they received the HPV vaccine. Here we saw the majority, 57% said yes, and those who were more likely to have received the vaccine identified as bisexual. And then we also asked about mammography and colonoscopy. And mind you, this was also pre-pandemic, so of course these numbers might look different when we collect more data. So only half of them had reported getting a mammogram in the last 2 years. Again, this was selected by age, so those 40 and older answered this question. And then the respondents who were less likely to have had a mammogram identified as bisexual. And then we also asked if they had a colonoscopy in the last 10 years. Here we had 62% had said yes. Now for the respondents who were more likely to have a mammogram identified as cisgender females and lesbian as well. So again, these numbers are nowhere near our guidelines for colonoscopy. You want to see around 80%, and we're not seeing those numbers. So they're not getting screened. And then we also asked about anal paps. And we know that anal paps, there's no guideline right now. It's not recommended by all healthcare providers, but some healthcare providers do recommend it for MSM, men who have sex with men, because they're also 17 times more likely than other men to get anal cancer. And so there is a way to be able to detect these abnormal cells through anal pap testing. So we asked that question, and 81% of our respondents said no, with a 10% not being sure. And that's not uncommon, because when I do discuss LGBTQ health and we talk about HPV and anal paps, most of them don't even know they exist. Now, of course, the respondents who were more likely to have an anal pap identified as cis males and also as gay. And then we asked, have you ever received LGBTQI tailored cancer information? And the answer, the overwhelming response here was no. 92% said no. So we really need to do better to provide information, cancer information, that is tailored to the LGBTQI community. And then we start asking about other behaviors. So that was cancer screening behaviors, but now let's look at the other behaviors that could put them at higher risk for developing cancer. We asked if in the past year they've had 3 or more alcoholic drinks in one day, and the majority, 69%, said yes. Now, those who were more likely to report this were cis men and gay men, and those who were less likely to report drinking 3 or more drinks were bisexual. And then we asked about tobacco exposure. We asked if they had smoked in the past 30 days, and the percentage here was actually pretty high. It was at 19%. And that is almost double the smoking rate in California. In California, our current smoking rate is 10.1%. And so at 19% in the LGBTQI community, that's almost double our smoking rate. And the respondents who were more likely to have answered that they smoked in the last 30 days identified as trans women. Now, we also asked if they were exposed to secondhand smoke, and now this number was actually bigger. Respondents that were less likely to have been exposed identified as lesbian. Then we asked about nutrition and physical activity. So how many of them had 5+ servings of fruits and veggies? Here, the respondents were more likely to get at least 150, for the respondents here for fruits and veggies, we didn't have anything in terms of statistical significance for specific groups. But this number is not too different. It's about a third. And in the US, only about a third of adults eat the recommended serving. So it's bad all across. And then for 150 minutes of physical activity, we did have the majority actually say that they were physically active. And I'm just realizing when I share this file, it's not showing you the percentages, even though I added them. But this is much better than the US. In the US, only 23% of adults exercise the recommended amount. So we're doing much better here. Now, the respondents who were more likely to state that they were getting this exercise identified as cis males and as gay. And those who were less likely identified as cis female, as lesbian, and as gender fluid or nonconforming. And this kind of relates to the research that we know that lesbian women tend to be more overweight. Now, in terms of unprotected sex, these behaviors, we had a majority of the respondents, 77% said that they practice unprotected sex. So, you know, in discussing HPV and other viruses that are sexually transmitted that may cause cancer, this is an area of concern. And then another area of concern is the regular exposure to UV rays, either via sun exposure or tanning. We saw here that 49% of them said that they were exposed to UV rays. And so those who were less likely to have reported this were identified as bisexual. Now, compared to the US rate, we see 49% here. In the US rate, 33% of adults are regularly exposed to UV rays. Now, which group stated that they were more likely to be exposed? Those were those who identified as cis males or as gay. Now, here's some of those demographics of the people that we surveyed. So here you see the education level. So most of them had some college or were college graduates. And then here you see some income. Here, most of them made less than $50,000 a year. We also know that 79% of them were insured. 15% of those were insured through Medicaid or Medicare, and we had 4% of our respondents who were uninsured. Now, because one of the results said that there was no LGBTQI tailored information, we decided one of the first things we did was to create this cancer screening and prevention tips for the LGBTQI+ community. So we put information here on cancer screening and prevention, a little checklist. We made the colors relevant, you know, using the pride colors, had some pointers here in terms of what they can do to reduce their risk. So really this project resulted in the development of this LGBTQI tailored flyer promoting this early detection and screening. And then we also developed a 1-hour training presentation to increase awareness about the importance of gender identity, pronouns, and using inclusive language so that we were able to build more welcoming healthcare environments for members of the LGBTQI+ community. And it all stemmed from that question that said, you know, I'm afraid to share my gender identity or sexual orientation. This one stemmed from the fact that most of them said there was no information tailored for them. So then for the training, we really developed the training using a co-design process in collaboration with trans and non-binary individuals, as well as representatives from several agencies who serve the LGBTQI community. And the whole point of the presentation was to gain a fundamental understanding about why pronouns matter, learning how to use gender pronouns, and then becoming more comfortable using this gender inclusive language. And then we had a 12-question survey so that we can evaluate the delivery and content of the training. So the training was implemented with 3 large healthcare organizations in California. We trained a total of 327 staff members that participated. And really the preliminary findings suggest that the presentation is appealing and engaging. They also suggest that the presentation increased the participants' understanding of why pronouns matter and how to use gender pronouns, and then using gender inclusive language. You can see that here from the results. So the dark blue is strongly agree, the gray is agree, and then we have the light blue, which is neither agree or disagree. So we had no respondents who disagreed, but these were the responses for if they understand why they matter, if they're comfortable using it, and if they would recommend the training. So for those of you, we're still collecting information, and we decided to expand it to cover all LGBTQI individuals, not just who identify as Latinx. So here are the QR codes to those surveys, because we're still collecting that data. It's anonymous. And here you see some of our partners that are involved. So it's not just a City of Hope project. I mean, we're taking the lead in terms of collecting the data and analyzing it, but it is definitely a community collaborative project, and it's not our project, it's co-ownership with this task force and all the members of it. And I just want to talk a little bit about, the community engagement part and the Latino engagement portion. So we know for the barriers that were identified for Latinos to participate in research involve things like mistrust, competing demands, unintended outcomes, lack of access to info, stigma, health insurance coverage, and then also legal status in the US. So wanted to cover some things for those of you who might be interested in engaging community patients or participants in your studies. Things a little bit about Latino cultural values. So one of the first ones is personalismo, which really the concept of personalismo is often defined as formal friendliness. It basically means that Latinos place a great emphasis on personal relationships. Latino culture is both people-oriented and collectivistic. So it means that Latinos generally value personal relationships over status, over material gain, and institutional relationships. So we really like these personal, warm relationships. So for this, direct contact is often preferred, right? So, and that's something we were afraid that we lost during COVID, but you can do it over the phone or virtually, as we learned. And it's really important to establish these good relationships and get to know people, even if it's a patient, get to know them, know about their family, about their life, about their well-being. And, beginning meetings with polite conversations and being attentive. And then also, this is very important, taking your time. You can't build relationships in a quick second, right? And this applies to community partners. Sometimes I've worked with partners for years before we actually implement any programs with them. It could be 3-4 years before I build a relationship. And then if possible, we also recommend you communicate in Spanish if you do know the language. And then, being natural and being friendly with a smile or brief eye contact. And then physical gestures like handshakes or placing a hand on a shoulder, it really helps communicate that warmth. And not everybody is comfortable with that, right? So you do have to ask at the beginning, but oftentimes at the end, and I don't know how that's going to change in COVID, but I know a lot of our participants, our meetings end in hugs, especially after being 12 weeks with them, like in Eat, Move, Live. But we really want to make sure people are listening carefully and making sure you're not appearing distracted or uninterested. And then also share your own experiences. Eat, Move, Live was littered with my personal experiences and my family experiences. Also, our health educators do the same thing. I talked about my struggles with weight, the changes that I've made, the struggles I've had with the scale, and how I've learned to focus on other numbers like my blood sugar, my blood pressure, my cholesterol. So it really makes you relatable. And it's just really common courtesy, to be honest with you. So then the other one is simpatia. And this doesn't mean sympathy, although that sounds like a simple translation. It's really an emphasis on politeness and conflict avoidance, and showing that warm and caring attitude and having a positive attitude, right? Making people feel comfortable, offering to clarify information that's not understood, and again, taking your time. And also, there might be other concerns that have nothing to do with their care or their participation or with community partners. You might be wanting to talk about a specific study, but that's not their interest. That's not their need. And so you have to make sure that you're addressing their need. And then some other cultural values include confianza, which is the Spanish word for trust. And again, this is largely based on personal relationships. So you can see how a lot of these overlap. It's the idea that a person knows us or is one of us, right? And it really outweighs any credentials or professional accomplishments. Again, here, taking the time to get to know people as individuals, making an effort to communicate in Spanish, even if it's not your primary language. I know a lot of people my parents who were monolingual Spanish speakers who now speak English, but English is my second language. And so I grew up, being the family interpreter at 6 years old. My parents appreciated when somebody tried to speak Spanish with them. Even if they didn't know her very well, they felt like that person cared enough to even try to speak the language. So if you're not comfortable with your Spanish, just give it a try. People are so appreciative and they're so forgiving. I screw up my Spanish often and they'll correct me, and I'm very accepting of that. I said, thank you for helping me, and they're very understanding. And then again, convey that you have their best interest in mind. And then again, work with community champions or liaisons who are established in the community, like promotoras or church leaders. And then importantly too, be open and honest and be okay with saying, I don't know, but follow up with saying, I will look into it and get back to you. That helps promote that confianza. And then promoting community ownership and making sure that they understand that they're co-owners. We share the data with our community partners. This is their data as well. And then we help them use that data to apply for grants so that they can sustain it. And the grant solely goes to the community partner, and we're just offering technical assistance. And then there's respeto, which is respect in all interactions. When we have a special consideration for certain populations, right? So we consider, special respect for the elderly, the educated, or people in authority. That means using the word usted instead of tú, because we have formal language and informal language. Addressing by name, using the word señor, señora, don, doña, señorita, and those are all different levels of, trust and relationship. And then last but not least, we have familismo, which is the idea that the family is the most important unit in the Latino culture. There's really an emphasis in family, loyalty, cooperation, interdependence. And really, you have to involve the family in the decision making. The decision is just not the individual, it's for the entire family. We know that medical decisions are often made as a group, and family members have a lot of influence in medical decision making and also in their health behavior. So we really give patients time to confirm with their family members. We do not rush the process. And then we also interact with family members, making eye contact with them, talking to the family member, encouraging the presence of significant others and families at specific appointments. So really, you need to really adequately characterize your target population. Who are you looking for? Are you looking for older women, monolingual, immigrants? Also involving them in the planning efforts, pre-testing recruitment messages and strategies, and then giving something back to the community, right? It helps build your credibility through community service. We offer a lot of free screenings. We offer a lot of free programs, making sure we're meeting community needs before we prioritize any of our needs. And then we enhance our credibility by working with community champions. As I mentioned, we work with promotoras, with church, with community centers and the leaders there. And then we try to identify and remove any barriers to participation by providing either transportation vouchers, gas gift cards. Like I mentioned, we don't necessarily offer daycare. In some events we do, but we also allow them to bring their children, or taking place at community venues that people already are comfortable with, already go to, already know. And it's weekend hours or evening hours. We've often done Eat, Move, Live on Saturdays and at nighttime or early in the morning. So we also implement the community health worker or promotora model, right? And as I mentioned throughout this, all of our work is partnering with community-based organizations and really promoting the balance of spirituality, faith, medicine, and science. A lot of times people use what we call here complementary and alternative medicine, but within the Latino culture is considered traditional medicine. And so we have to make sure that we're not judging people for using those those avenues, and maybe talking to them about it. And as I mentioned, providing transportation vouchers, using culturally relevant information, and then maybe your staff cultural competence. So hire bilingual staff that speak the language, but most importantly, hire staff from the community. Staff that actually knows the community. I'm born and raised in East LA. I grew up here my whole life. I lived down the street from my elementary school, 4 blocks away from my mom. Talk about familismo with me. My mom says I have mamitis, which I guess it translates to I'm still tied to her apron strings in English. But it makes a huge difference. I know the community. I'm comfortable in the community. I know different programs because I lived here in different community centers and organizations. Now, why should we bother with community engagement? we know that by engaging and supporting the empowerment of community for community health decisions, making and action is really critical in health promotion, health protection, and disease prevention, right? We do it because, we want to help the community, but we also want to be able to meet their needs. We can't just assume we know what's best. So we really need to build on the strengths and resources of a community, coming to this with, not looking at this through a scarcity lens, but actually seeing how rich the community is, how much they already have. And, we're not there to empower them. They have a voice. It's our job to make sure that that voice is lifted. We foster co-learning and capacity building. You will have to agree and communicate on a clear purpose and a scope. And choosing appropriate engagement methods according to that purpose and scope, and always getting feedback. How is this going? It's a constant process. And then community engagement is on a continual basis. It's not a one-off exercise. It's something that happens constantly. Now, I want to thank, our staff who did this, and then also our funders. So you can see here, multiple grants helped to fund some of this work. But most importantly, I think last but definitely not least, we could not have done any of this work without the vital collaboration of our community partners. They're the ones who really made all of this possible. So thank you. And I think now we have Q&A, but here's my email.
Thank you, Mara, for such a great presentation highlighting the critical areas that are open for improving health of health disparity populations. And I'd like to jump now into the questions from our audience, but just as a reminder, you can submit questions using the Q&A feature on the right side of the screen. Just type in your questions, select the option to send it to all panelists, and hit submit. But for our first question and comment, and I think the questions, the way they go, we'll first talk about the first program on Latinas and food and nutrition and physical activity. Somebody said that project is very impressive, and specifically speaking about the retention, what was it from the beginning of the study through the end? Because you did mention you recruited 50, and I believe there was 36 participants.
38.
38.
Yeah.
So from the beginning to the end, and how many ended up at the end of the study?
So yeah, and that's where I mentioned we learned the hard lesson that oftentimes people just came for the free incentive, which was a Fitbit valued at almost $70. So a lot of them came to the first one, or maybe didn't even show up. And even though we had staff calling them, just other things got in the way. So we did have 38 fully participate in the program, and then 83% of those actually completed 75% of the 12-week classes. I think we only had one or two who maybe came to a couple of classes, and we had a higher retention rate in the intervention group, which makes sense, compared to the waitlisted control, which was started 3 months later. We had to hold on to these people for 3 months, but not really have contact with them. So we were really impressed with that. The one we've been really impressed with is our virtual sessions. We've actually had higher retention in our virtual than our in-person ones, and we were surprised by that. We thought, the intimate environment of, in person, we were going to lose that with the virtual session, and we've actually been doing really well. And I think it's attributed to our wonderful health educators who do a great job of building these relationships with these people, and actually being in contact with them and being, like I said, just building that trust, that, personal relationships, all the different cultural values that I talked about.
Good. And, something that you just mentioned, the in-person versus the virtual, especially given COVID times, somebody had a question about where these participants are located. Are they primarily urban, or are they rural? And how would that make a difference, especially now that you've translated your work into virtual?
Yeah, so all of these were more urban, suburban areas, and we are going to try this out with the new study. It's going to be in, it's California or LA's version of rural, I guess. So it's a little different. We don't have too much of a rural area. So we do have some FAR zip codes, the frontier and rural areas. And so we are going to try that out. And we are looking to see maybe in order to bridge the digital divide, perhaps having hotspots that we loan out. What we've done in terms of our promotoras, the work that we've done, we've actually created loaner libraries with tablets and hotspots. to be able to overcome some of that digital divide. But that is something huge that we're taking into account. That's with the virtual, we are leaving behind some of the most underserved that maybe don't have access to a smartphone or don't have access to any equipment to be able to join some of these classes online. And then a little addition to that, we did have to have some preliminary training with a lot of our community partners on how to use Zoom. So I've become a pseudo Zoom expert on teaching people how to be able to use it and the different features, because again, we have to meet our community need. And so now they're able to do their own Zoom classes, but we've been able to provide some training in that as well.
That's great. Another question that came in regarding lack of knowledge among the pre-diabetic status, could you comment on some of the possible barriers that might contribute to this lack of awareness and also thinking about access to healthcare?
Yeah, so a lot of if you noticed, a lot of our participants were low income, some of them were uninsured. We had also some that, we didn't collect this data, but we knew because a lot of our participants disclosed them, but some of them were undocumented. And so a lot of times it could be this lack of access to care. But I think oftentimes too, people don't know the symptoms and aren't getting those regular checkups, again, because of the lack of access to care, but there's also a lack of knowledge in terms of the symptoms of diabetes and pre-diabetes. So I mentioned, I gave a quote from one of our patients whose blood sugar, I think her A1C was almost 13. It was very high. And so she was already starting to get like blurry vision, I mean, she had some of the symptoms, but, she hadn't gone to go get a checkup, but she was also uninsured. So luckily we have partnerships with federally qualified health centers. So we were able to take, send her to the federally qualified health center to then get her blood sugar under control and be able to manage her diabetes. But we were completely flabbergasted by the idea that 66% of our participants had undiagnosed pre-diabetes and diabetes. Now, when it comes to pre-diabetes, that's much more common in terms of not knowing you have it. Because you don't really have symptoms, it just puts you at high risk for developing type 2 diabetes. You're not at the stage where you have the symptoms yet. And then sometimes doctors don't really ask for A1C, right? They're looking at fasting plasma glucose. That's actually, more typical to see. A lot of our patients were like, I never knew about A1C. And, they have to actually request it in order to see where they lie. And so it also happens, I don't know if it's that physicians aren't asking the right questions, maybe they don't have time, whatever the case may be, but we did see that large number and it was kind of scary. Yeah.
Yeah. Well, I know it's almost the top of the hour. I want to be respectful of everyone's time. I want to thank Myra for joining us. I know there are several questions that came through we weren't able to address, but I want to encourage others that if you have questions about the programs that Myra has been conducting, the trainings, and whether that information can be shared with the group, please feel free to email her. I'm sure she would be happy to answer some additional questions if you have them. And I'd like to also at this time mention an upcoming NCI-sponsored virtual meeting that is titled Cancer Epidemiology in Hispanic Populations. I know there is a slide available for that. This meeting will be held virtually on September 14th through the 16th later this year. And if we can show that slide. It's available. This slide. So you can see, as I mentioned, this workshop will be held in September. We welcome everybody to register once that becomes available. And I want to thank once again Myra for joining us and enlightening us in some of the work that she's been doing over the last 14 years in the West Coast. Thank you.
Thank you.